As pharmacists, we have a role to play. We can help the doctors optimize the choice of antibiotics that they use. We can help them with the dosages. We are the custodians of the drugs. As AMS picks up, we need to co-lead with these ID physicians and help them make choices that are safe, efficacious, and cost-effective. We handle a lot of patients coming in for prostatectomy. Now, some of these may have urinary tract infection. So the standard at the Aga Khan is the urologist, first of all, manages the infection. Now, there are times you'll come across a prescription having cefuroxime, 1.5 IV TDS, or 500 POBD. So when I meet such, I pick up the phone and educate the doctor a bit that the uropathogen there is E. coli, and the cefuroxime is a wrong choice. It may not work well, and recommend ceftriaxone. So a switch there would be in order. Then at the Aga Khan, we accepted the fact that we have run out of options, the pipeline is dry, and decided to restrict a select group of antimicrobials that I'll show you. And then the med farmers can be a handful. If you let them have their way, you can end up with many drugs in your formulary that you don't need. So we have a subcommittee that vets what must come on so that we don't have a very big arsenal that we cannot handle well. Then, of course, I do a lot of work with the children where we discourage the use of doses like 5 ml augmentin BD. We insist on weights being there and the dosages being weight-based. So when the prescription is presented, we verify that it's accurate. And in our PHDU, twice or thrice I've come across prescriptions where the doctor was managing MRSA, but they dosed linezolid wrongly. In their mind, they know it's BD. But the literature says for the younger children above 11, you do 10 milligrams IV TDS because they metabolize it faster. So they have intervened in such cases. Then in the antimicrobial guidelines that we did as a committee, a stewardship committee, we earmarked a whole section for renal dosing because the doctors don't know these things. They prescribe a dosage for a normal patient, so harm could be caused if you don't intervene as a pharmacist. Our guidelines will be handy even for those who are just beginning as interns to dose this category of patients correctly. And then I talked of ceftriaxone earlier. Our pediatricians use it in gastroenteritis, in bronchopneumonia, in meningitis. So when I see it prescribed, I dig deeper into the file. If it's a case of meningitis, I insist on the higher dose, 100 per kilo, 100 milligrams per kilo. For the GE, we may go as low as 40. Because there are residents there who may not be conversant with the dosages. So if you are not keen, the kids may be undertreated. So there's room there for intervention, for stewardship.
Unwanted pregnancies are among HIV-infected women have negative effects on the immunity as well as subjects the woman to unnecessary emotional distress. And unfortunately, our role as pharmacists in, offering reproductive health care is not fully exploited. Because in the government sector, you find that reproductive health has been focused to the nursing department. And literally, we as pharmacists, the only thing we offer our patients is limited, like it's limited to pessaries and other medication that we dispense to outpatient patients, but we never really get to interact when it comes to offering contraception and advice on how to use this medication. After all, it is in our docket.
It's our work to deal with individual patients, not batches, not units, not wards, in groups. No. You give our services to an individual patient and make sure that that patient can actually see that they've been served by a pharmacist. I have this belief that any pharmacist is actually a clinical pharmacist. If you are manufacturing, you're concerned about the amount of medicine per formulation because you know if you overdo that, then it will not be safe for the patient. If you are in quality control, you are making sure that the amount of medicine is within the label claim. If you are in quality assurance, the same thing. If you are in pharmaceutical analysis, you're always confirming that you are weeding out medicines that might not be useful to the patient, or even those that can be potentially harmful. Pharmacy is a clinical professional. There is nothing called clinical pharmacist. We are all clinical, because at the end of the day, the end of the pipeline is a patient.
I feel that as a profession, we are now adding more value to the patient. We are adding more value to the overall healthcare system, because pharmacists are actually making an impact, playing their role, coming out, being bold, being part of multidisciplinary team, and adding value to the whole healthcare chain.
Today we were having the 14th annual symposium. We normally hold our symposiums in August every year. This year we can say that there is much improvement. As happens every year, we have been improving every year. A show of appreciation of the work that HOPAK is doing, because the numbers and the quality of presentations are on the increase every year.
We have postgraduate clinical pharmacy and pharmacovigilance programs, and these programs have actually produced quality graduates. If you look at most of the presentations that have actually been done in HOPAK, they are very high quality presentations which can easily fit into an international conference, and that is because of postgraduate training, very good undergraduate training as well. So I've actually, when I come to HOPAK, I'm very proud, because I get to see what my students are doing. They get to, you actually see that your training has an impact on practice.
I had the privilege of being the convener for this year's 14th HOPAK Annual Symposium 2018. And I'm glad that it was such a successful symposium, and everything went well. We were basically focusing on our key theme of transforming patient outcomes, opportunities in pharmacy practice, and with the realization that pharmacy is moving to the next level, whereby pharmacists are more involved in multidisciplinary teams to ensure that patient outcomes are coming on well, and that there's patient safety. We had a number of presentations from different hospitals, different pharmacists who work in various fields in pharmacy practice, giving us a snippet of what their daily work involves. So in the course of the program, we had presentations that were podium presentations that had a scientific look, and we also had what we are calling the PAL presentations.
We formed the Hospital Pharmacy Association about 18 years ago as a small group of like-minded people, and the concept of registering it as an organization that meets our day-to-day needs came up as a result of that. We have had our strength, especially in professional development. The specific area that we've really concentrated on is having annual symposia. We have also looked at opportunities to hold monthly continuing professional development meetings, and also forming the gap in areas of pharmacy practice where we encourage issues like specialization and specific focus areas for those pharmacists who are practicing within the hospital sector. We have made a lot of strides since the Hospital Pharmacy Association of Kenya began. And some of the things that we've had is increasing our membership. We now have a comfortable membership of close to 150 individuals. We have also hosted, this year, we hosted our 14th annual symposium that brings together close to 100 people on a year-to-year basis to discuss the challenges and to share practice ideas in hospital pharmacy. HOPAK has grown.